Okay, welcome everybody. Welcome everybody on Zoom and in Southland. Thanks, Kat, for stepping in. First, a few housekeeping things. So this session is being recorded. I hope that's okay with everybody. It's just so that we can then provide it to other people who have not managed to make it today. If people in Zoom land, if you could keep yourself muted, and then when you want to participate, unmute yourself, just so that we can keep the background noise down. Welcome to everybody. Big warm welcome. Thanks for coming. There's about 6 people here, and there's 2 people in Southland, but there's about 270 people who are on this course. So hello to everybody who's watching on the recorded versions, okay? It's really worthwhile turning up to these because there's a lot of interactive sessions, and it's really about meeting of minds, this sort of thing. So it really does pay to come along to them. This session, QI102, fits with QI102 module in the course, which is 13 modules long. And this is probably the linchpin of quality improvement as IHI see it. And it's a really good starting point for quality improvement. It's going to introduce you to what they call the model for improvement. It's the one model, it's the single language that a lot of people will understand. And if you can speak the same quality improvement language as most of the other people, you're already halfway there. So just basically working with that, knowing how to set it up, and what does PDSA mean, and the concepts around that. So we're going to, in this hour, we're going to talk about the model for improvement, how about to set an aim, choose your measures, and develop changes, and then how to test them. And then there'll be a video exercise after that, and then we'll actually work through developing a change initiative. Okay, so how can we improve? Well, there's 3 elements to making things better. One is that there needs to be a will to improve. If there's no desire to improve, nothing is ever going to change, because nobody's going to understand why it needs to happen and why all this effort needs to go in there. And then second of all, you need ideas. If nobody has any ideas on how to prove something, then maybe that's a problem that's completely unsolvable. Doesn't happen often, but you've got to have ideas. But the third thing, and this is what we're talking about, is execution. So you commonly have a will, you commonly have ideas. That is what we commonly have in healthcare. But it's the execution where everything commonly falls down. And that's what the model improvement tries to address. So there are other improvement methods apart from the model for improvement. There's hundreds of them. There's Lean, which was developed out of Toyota, and Lean is just a collection of tools, concepts, ideas, and processes that help you get to a state of efficiency. Six Sigma is another slightly different way of looking at things, and that's to do with eliminating waste and all that stuff. They all developed around the same sort of ideas, but they're just written in sort of a different way, really. So it's not really which tool you use. It's more a case of having a common roadmap for how to improve. It's about speaking the same language and everybody knowing what we're trying to do next. So that's why the model for improvement has been chosen, because it's very simple. It's quite familiar. Even if you haven't seen this, you'll realize that the concepts are very familiar. And it is based on evidence as well. So there are evidence that this tool can deliver outcomes. It's not a panacea. It's not going to fix everything. And it's certainly not a good model in some certain situations. For example, whole-scale system level change. It's very difficult to apply this model to that. So, but it is a good model for, I would say, 80% of change initiatives. So the first step in the PDSA, in the model for improvement, is starting at the top and asking these 3 questions. And this really sets up what you're doing, why you're doing it, and how you're going to do it. And the first question says, what are we trying to accomplish? So, you know, what is the problem? What is the problem we're trying to address? And why are we doing that? So that's the first thing. That's where we start. And so who's the target population that we're trying to improve this for? When do we want to do it? And we want to write this out in objective language. So we don't want, oh, it'd be nice to do this and make this a bit better. It needs to be written like SMART, so that's specific, measurable, achievable, realistic, or relevant, and time-bound. SMART is something that people will probably recommend. That's basically what SMART is, but we haven't used SMART. So a little exercise. If people in Zoom land, you could use the chat maybe to answer this question, the chat function on Zoom. And in Southern, you probably just confirm amongst yourself. Here, Denise, just maybe.
Excuse me, James.
Yeah.
This is Fiona. Can you change how you're sharing your slide?
Okay.
Because it's not good from a Zoom perspective. I have all your notes and stuff down the side. So if it's not moving along.
It's not moving along. Okay. Right. Let me see if I can sort that out. 1 second.
Thanks.
Sharing is paused. Bring your share window to the front. Is this better? Can people see that?
Yeah.
And I'm moving through the slides. Can you see that?
Yeah.
Okay. Apologies for that. Okay, so I'd like you to just confirm maybe with the next person as to which is the better aim statement. So first one is reduce all types of hospital-acquired infections by as much as possible, as quickly as possible, or decrease the rate of hospital-acquired pneumonia for patients in the ICU from 23 infections per 1,000 catheter days to less than 5 by May the 1st. Second one, yeah, that one's quite easy. So that's right, there's the second one because it's much more specific, it's measurable. So we got some numbers in there that we can measure ourselves against, and we can see if we're getting how far from 23 down to 5 we're getting. So yeah. So the second one is how will we know changes and improvements? And here's where our measures come in. There's 3 types of measures. There is outcome measures, which is the thing that we're trying to improve. So that is the end goal. So it might be like, for example, the number of infections associated with catheters, or it is the number of deaths we have in a unit, trying to get that down, or the number of complements that we're trying to achieve in a month from a certain unit. Any of those is an outcome measure. A process measure is something along the way that might tell us that we're getting to that outcome. So it's something to indicate our processes are going well. So for the catheter-associated infections, it might be how good is compliance with a catheter bundle, for example, where you have to do a checklist to make sure you're doing all the right things to reduce the infections when you're putting these lines in, or that we are, in order to get compliments, we are making sure that we're giving a smile to everybody as they come to the doors, for example. Balancing measures are the things that might happen inadvertently and actually go in the opposite direction. So they're the sorts of unintended consequences And there may be certain things that you really want to keep an eye on to make sure that you're not affecting that in the wrong way. So, for example, in the catheter-associated infections thing, it might be the amount of time it takes to put in a catheter. If your measures are going to actually increase that time from 10 minutes out to an hour, then that might not be feasible. And you would certainly want to measure that in your early stages of that to see if that's a problem and to try and mitigate against that. So often balancing measures are the one thing that people kind of forget about or find it difficult to think about, but it's really important. Which measure is which? Again, just have a quick look. So the first one is average number of times patients receive recommended oral care in 24 hours. Patient and staff satisfaction scores and the rate of hospital-acquired pneumonia per 1,000 capital days. So balancing, process, outcome, which one is which? So we'll take the first one. Process. Hands up if you agree with process. Yeah. And then the second one, patient and staff scores. What would we think that one is? Balancing, yeah. And the rate of hospital-acquired pneumonia per 1,000 capital days. Outcome. Okay. Yeah. Well done.
Can you just, I fell asleep with balancing. What is it again, balancing?
So balancing is measuring things that are unintended consequences, things that might go wrong as a result of what we're doing.
Right.
So we're trying to improve this over here, but then inadvertently this over here starts to get worse. But we want to keep an eye on that, and we don't want to get lose sight of that. Yeah.
And they sometimes hard to measure because it's like that example, like satisfaction, like it's subjective.
Yeah. Yeah. So sometimes it's hard to measure, and sometimes it's a bit more woolly. But if you're say if you're changing a patient pathway, and you are really focusing on the say the performance of that pathway in terms of how quick it takes to get the patient through the system. So you start taking out bits of that pathway in order to make it more streamlined. For example, you might reduce the number of clinic visits that person has along the pathway because you think that's unnecessary. So you think overall your pathway is going to be shorter, the patient's going to be happier because they got from the beginning to the end quicker. But your balancing measure is complaints. And you might find that they're starting to complain that they don't get enough doctor-patient time, for example.
But how do you know if you haven't done it before on the same amount of complaints?
Yeah, exactly. You need to measure these measures before, during, and after your change. Absolutely.
I think like the weekend discharges that we're working on at the moment is a good example, because there's no point discharging people a weekend if then they're getting readmitted, you know, by ED.
Yeah. So readmissions is often a balancing measure. Yeah. Absolutely. Any other examples? Okay. So the third one is, what change can we make that result in improvement? This is asking, you know, what are the new things that you're going to do, or what are the things you're going to stop doing in order to make things better? Okay. And this is where your ideas and brainstorming and innovations and different ways of working and all that stuff, that's where that comes in. Okay, and that can be the sort of fun part of it, because that can be quite a creative part of your sort of planning stage. So there are lots of different change concepts. There's eliminating waste, there's improving workflow, optimizing your inventory. You can read all the ones there. Has anybody got any experience of seeing some of these small things being proposed or in action in your areas? And feel free to unmute yourself on Zoom and join in. One example, for example, managing variation. Variation comes from people doing different things to the same sort of scenario. And the way we manage that, maybe in clinical pathways, is to write out a guideline, clinical guideline for how we expect that person to be treated if they present with these sorts of things. So clinical guidelines are everywhere. You know, we have them in wound care, for example. We have clinical guidelines in managing pancreatitis. And those things are set there to try and reduce the variation so that patients get the same sort of thing if they are within that same box. Has anybody got any experience of trying to work towards a clinical guideline?
Okay.
Yeah?
Yeah.
Yeah. What clinical guidelines?
For breast injury prevention, international guidelines.
Yeah.
Yeah, that's one. Then Australian guidelines for venous leg ulcer treatments.
And I would expect that you would expect lots of district nurses to try and use those guidelines when they're caring for patients in the community.
Yeah.
And do you see variation?
Variation of
So
treatment?
yeah,
Yeah.
yeah. Outside the guidelines or within the guidelines?
Outside the guidelines and within the guidelines.
And what's the impact of treating patients outside the guidelines?
It could be devastating. It's could be really, delayed healing.
It's a delayed healing.
Yeah, or no healing.
Okay, and what implication does that have for the system, the health system?
Increased waiting times, more costs, in all sorts of aspects, more pain, quality of life.
Are the surgeries delayed?
Yeah, surgery delay.
Yeah.
Oh, yeah, plenty of people wait for surgery until this little thing with wheels down there.
Yeah.
You can't change your hip.
Yeah.
And they don't follow the guidelines yet, so
Yeah.
I can't go on forever.
Yeah. So that's a good example of where variation can cause inefficiency in the system, which leads to increased cost, increased resource demand, and poorer clinical outcomes. And so that's where clinical guidelines are attacked. All patients are different though. Yeah. So do we think, what percentage of patients do you think should fit a particular clinical guideline?
I always say when I teach, I always say, well, clinical assessment can override the guidelines. So I'd say maybe 90%.
Okay.
But there must be room in the, for clinical assessment. For example, breast injury prevention. The patient is not improving and going down, but it doesn't fit the guidelines you have. Well, you usually give it a judgment and basically override the guidelines.
Right. Yeah. So we've got protocols, and we've got what we call protocol violations. That means people who are overriding the guidelines. What percentage of protocol violations is acceptable? You said 90%, 10% of violations. Anybody else got any offerings? It depends. It depends on the guideline, but probably the Pareto rule applies, which is the 80-20 rule. That usually a good protocol will be adhered to about 80% of the time, and you'll probably get about 20% where there's a protocol violation. So if you want to try and see how well your guideline is doing, you might want to measure protocol violations, and you want to see, is this guideline being followed or is it not being followed at all? And if it's not being followed at all, why not? Go and find out.
So I'm not clinical. So what I was thinking when I was listening to all this is, I don't know how this happens. What if there was, say, new research that suggested that the guidelines should be changed? How easy is it for them to be changed? Would that take 10 years? Would it take a year? Would it?
It's a process. You wanted to say something.
Yeah, because we just review, we do it every 3 to 4 years. We review guidelines, so those 2 guidelines.
Yeah.
They're all constantly updated, and during that time, Unless, well, we're not changing the guidelines, we should stick to it, and then look at in 3-4 years what has been researched and published, and then we go from there. And then the guidelines always are probably 5-6 years behind anyway, by the time you write them up.
Yeah,
It takes it.
it's a long,
takes years to get published.
Yeah.
yeah.
True.
So it is an oil tanker
Yeah.
in terms of what the sort of the standard of care is. And new research and new evidence coming in takes a long time to filter into what we call standard care.
I read about it takes about 15 years for practice to change.
For innovations to be adopted, yeah, 15 years is probably quick.
Yeah, no, I don't want to think
Yeah.
15 to 20.
So it took thrombolysis 15 years to be adopted, yeah.
And it's not like there's one agency that says, all right, everybody in the world, you need to do this differently now because these guys are Oxford down there, whatever, you know, like surely it's.
So there is an agency, it's called the World Health Organization. But, you know, change, you'll understand in this course that change is not just simply about saying somebody at the top saying do this, because there are lots of drivers and restraints of change. You know, the things that are pushing the change forward, there's a lot of things holding it back. And those things vary across from where you are, from country to country, region to region, hospital, or even department level. So just because somebody says it's a good idea, it doesn't mean it's going to happen. And that's why it takes so long. Yeah, because there's.
Do you think in the hospital, because that's something that's not just within your department, you're trying to change, as soon as you start working, you're trying to join different departments together, but seems to fall over quite easy, or it's hard to get everybody to agree to do the change.
Yeah, it's hard to sort of get everybody, because there are a lot of competing interests. And that's why it takes so long.
It's not hospital specific, so I'm more a manufacturing background, and it's the same.
It makes us feel better, doesn't it?
So, I mean, we could talk about this for forever, but we'll carry on. So these are the different change concepts. Eliminating waste means trying to find where we're duplicating things. Improving workflow means trying to line things up in order of what they're doing rather than people going around in circles. Optimizing inventory, so that means not stocking too much of something and letting it going out of date, but also not letting something run out and then people having to go to the next place to get something. Enhancing the producer-customer relationship, that's basically just more patient engagement. Changing the work environment, so the actual layout of the space can help with efficiency, especially in places like ED and theatres. Managing time, managing variation we've talked about, designing systems to prevent errors. So unsafe systems are expensive because out of all the unsafe activity comes cost from having to deal with the aftermath of events and problems. So a safe system is cheaper to run, and focus on design of products and services. So that speaks for itself. So what changes could you improve in oral care in the ICU? So think along these categories in terms of oral care in ICU. How could you improve workflow, optimize inventory, change the work environment, manage variation, design systems to prevent errors? Any ideas from the floor, from Zoom?
You change the work environment, so you can easily get the equipment to do the oral care. But then I guess, do we have to go and audit?
No, you don't have to. So changing the work environment. So you're talking about getting the oral care equipment closer to the.
Yeah, because you can't walk away that easily from your patient.
Yeah.
What does oral care in ICU constitute?
Oh, so it's like cleaning their mouth.
Yeah.
Brushing their teeth. And it's high risk if you don't do it, can lead to ventilator associated pneumonia.
Yeah.
Yeah, it's quite just.
So it's a basic thing. It's quite
Basic.
important. It needs to be done routinely all the time, and it needs to be done every time. So it's something that could easily get it's easy not to get 100%. Yeah.
And I guess because I work in ICU, and we've got also we've developed it was like a form you fill out, so you know when the last person we do like an oral check of the amount, so you can keep comparing if it's changing.
Yeah.
And then you got to document when you did it, so that the next shift could see when you did last oral cares as well. And I guess like we would measure if a patient developed a VAC, so I'm not sure how much we could say it was meant to not have oral cares, but
Yeah. So you're talking about checklists, and that would be systems to prevent errors. You're talking about the environment making equipment easily accessible and nearby.
yeah, and improving the equipment.
Yeah.
Better brushes and things, and toothpaste and gels.
And by having the protocol and the checklist, that reduces the variation of what people do and when they do it.
Yes, in education.
Yeah. Okay, so here's what they suggest. Ensuring the supplies are there, and make sure that the supplies are consistently available, not too much, not too little. Training, policies, and auditing against protocols. Yeah. Okay, so we worked through developing our case for change, how we're going to measure it, and what we're going to do. So that's all the background work. That takes a lot of work. Okay. Don't underestimate how long that takes. And the reason why it takes the reason why it should take a long time is because it should involve a lot of people. Because you can't change on your own. Changing, it involves changing the whole team, and the team is made up of other people. So that exercise is not just to find out what we're going to do, but it's also to build a coalition, to actually get some buddies on board, so that when you come to actually trying to implement it, you've got other people there wanting it to happen and work too. So now we come to this PDSA cycle: plan, do, study, act. And it's very simple. It does what it says. So plan means, okay, so we're gonna test something that we've decided is a good idea to change. We're going to introduce a new protocol, or we're going to bring those oral care supplies to the bedside. So first of all, we're going to plan exactly what we're going to do. And your first PDSA cycle should be very, very small. It should be maybe one patient, or 1 day, or 1 hour, whatever it is. And we're giving you a clinical situation here, but it applies to administration areas as well. You know, if we're going to change the way we process our dictations, let's do it for just one letter or one clinic and see what that is. And the reason why we want to start off small is because change is difficult and it requires a lot of resource and energy. And if you put all your energy right in at the beginning to something that doesn't quite work, and guarantee the first time round it's not going to work perfectly, then you don't get the confidence from everybody else who's been involved with you. And then getting everybody to stay on board with you with the next one and the next one, the next one becomes difficult because you kind of failed already. Whereas if you start very, very small, it doesn't matter if you fail. We haven't lost much, people didn't put in much effort, and it's more of a learning exercise. So it's really, really important to start off small and don't get too ambitious too early. So then do is actually doing your small tests. So we're going to just bring those cleaning equipments just for one shift. We're going to put it in a special trolley right here. And then after that, we're going to study what happened. So we're going to ask the staff, how was it for you? Was this any better? What worked? What didn't work? Have you got any other ideas that might be good? And you would measure exactly what oral care went on and see if that did well. You would measure your balancing measures, which might be how long it takes to do oral cares, because time is also at a premium. And if some of your changes are actually making them spend far too long on oral care, so that's not good either. So make sure you measure all your measures in the study, and then you come around and decide, okay, so what went well, what are we going to move forward, what are we going to take forward to the next learning cycle, what are we going to change, or should we just stop this altogether and try something else? And then you go round and round, and as you go round, you get bigger, and as you get bigger, you start to get an idea of what things are really working, what things are not really working, and you're also gaining more support. Because as you start to work across a whole ward, you need to have everybody behind you. And the people who were doing it for the first time just on one shift will then talk to their mates and say, oh, I did this and actually it worked quite well. And that's how you build a coalition. Okay. So using the model for MFI, model for improvement, you set your aim, establish measures, you identify what you're going to change, then you test the changes, and you test and test and test and test before you eventually say, right, this is what we're going to do as standard, and that's what's called implementation. So I'm just going to now play a video where somebody's talking about the model for improvement. Just a second. This is the one. Yeah. Okay, I hope people can see YouTube. Just going to play this. Oh, hang on, wait. I need to make the audio work.
I'm going to talk to you today about Plan, Do, Study, Act cycles, commonly known as PDSA cycles. So let's just go over for a second what those terms mean. And I'll start by telling you that this is a method we use in science, we use it in everyday life, and we certainly use it in improving healthcare. So plan, by plan we mean we're going to run an experiment. We have a hypothesis, we're making a prediction about what will happen when we run this experiment, and we're going to determine whether or not that prediction holds up. That's where the do comes in. We run the experiment and then we study, that's the S. We see whether or not our prediction was in fact verified when we acted on our plan. Based on what we find, on the data we get from the PDS, we then revise our plan if necessary and act to change our plan and have another hypothesis and run another experiment. So that's pretty simple, and you're probably seen many examples of this in healthcare, even if nobody called it a PDSA. Let's look at an example of trying to prevent central venous catheter associated bloodstream infections, or CLABSIs. Now, we all know that a checklist has been shown to be very effective in getting folks to reliably do the right evidence-based practices when they put in a line, and that reduces infection. The question is, how do you actually get that done in practice? How do you execute on that evidence-based plan? Well, we know that among the things you're supposed to do when you put in a central venous catheter are to prep the skin with a certain kind of antiseptic, it's chlorhexidine, and to use a large surgical drape. Those are two of the elements of the checklist. The question is, how do you get them to be at the bedside reliably so that the care team has them at their beck and call when they're ready to put in the catheter? So the physician's ready to put in the catheter, and you have a theory that if you include the surgical drape and the antiseptic in the packet of supplies that the team brings to the bedside, the physician will always be able to do it. He won't have to be looking all over. She won't have to be hunting for these supplies. And that's your theory, and you predict this will improve care. So you do that experiment, and Lo and behold, not surprisingly probably, the drape is there, the antiseptic is there, the physician uses them when he puts in the catheter, and infection's probably less likely. That's a PDSA cycle in healthcare. So I know you're dying to try this in healthcare, and that's great, but I recommend that first you try it in your own personal life so you get comfortable with it, so that when you go to healthcare, you'll feel like, I've done this before, this isn't that hard. But I'm going to talk about, of all things, cucumbers. And I care about vegetables. I have raised beds. I spend a lot of time and effort. I don't want stuff to go wrong. So this year I decided I'm going to plant cucumbers and prepared the soil, put in the fertilizer, dropped in the seeds, 3 seeds to a hill. They sprouted. I thinned them to 1. Things growing like crazy. And I run it along my bed and looking at it with admiration. I come back from work to home and I see that it's been chopped off by a weed whacker. Turns out every Monday there's a guy that comes and he does our lawn, right? And he has a weed whacker and he chopped off my cucumber. And this results in a pretty stunted cucumber. So I said, well, look, I have a theory that if I prop this cucumber vine up on the raised bed more carefully, the weed whacker won't get to it. That's my prediction. And so I put the cucumber vine up on the raised bed, came back. By golly, the head was chopped off again. My prediction was not correct. When I studied the result, it was a disaster for my poor cucumber. And so I had to revise my plan. I had to act in a different way. My next experiment was to put a large flower pot in front of the cucumber vine, hoping that the guy with the weed whacker would understand that he wasn't supposed to meddle with this thing. And lo and behold, I come back, another PDSA cycle failed, and he'd been mangling my cucumber again. At this point, I actually thought about something that you probably use in your life, and we certainly sometimes default to in healthcare, and that's called brute force. I went to find the guy, the weed whacker guy, and basically grab him by the shoulders and shake him and saying, you're killing my cucumber. But I restrained myself. This is improvement. We don't want to have blame. We want to do things better and make things better for the weed whacker guy as well as myself. So my next PDSA cycle was to put the cucumber up on a trellis. I figured if I had a trellis, and I have a very pretty one, as you can see, it's in the shape of a leaf. It's really quite attractive. I propped the cucumber up on that so that a weed whacker really couldn't reach it. And lo and behold, look at it, it thrived. My prediction was get the thing out of the way so that the weed whacker absolutely can't get to it. This is called a forcing function. The forcing function is the darn weed whacker just won't get that high. He can't do it. And my cucumber's thriving, and I'm telling you, I had the best marinated cucumbers, a little onion, salt and vinegar last night, just like my mom used to make it. This was a really good PDSA cycle. So that's all there is to it. You can do that in your own life. You can do it in healthcare. Remember, you have to have a prediction. You have to start with a theory. Your job is to see whether or not your theory is a good theory. Most of our theories, we have some doubt, so go test it. Run a PDSA.
Great. I hope you enjoyed that video. I don't grow cucumbers at all myself. I'm sure we would all be. Sorry.
Hi, in this video, we're going to talk about PDSA cycle.
Yeah. Right. Next time you're doing gardening, please use PDSA cycles. So we're gonna do a little think exercise now. I'm just going to share the PowerPoint again. We're just going to skip that discussion. So this exercise here, I want you to maybe in little buzz groups, so maybe 2 or 3 people, select a small area in your work that could be improved and make it small, okay? If you're going to think about a grand scale change, it's going to take too long to think through, and also it's too complex. Make it really simple, like, I don't know, we run out of paper clips all the time, or people always get lost and they're asking me directions to this place. They're always knocking on my door and interrupting me, or something very small like that, okay? try and describe that problem in one sentence to your colleagues, and then we'll do the next thing in a couple of minutes. And people on Zoom, you could do this exercise yourself on a bit of paper, and as it doesn't need to be in healthcare, it could be something in your personal life, like cucumbers if you want. And so we'll come back in about 2 minutes, okay?
Hi Blair, can you hear me there? Were you going to put us in a chat group, James?
Yeah, I can do, hang on.
Or
The language
Disappeared.
Oh, hi. Not sure if Blair's back as well.
Yeah, I'm still
you're
here.
there.
We were busy discussing. I think we're in the main group again.
Yeah, you're all back. So it's just a quick exercise to sort of start to think about problems, and maybe if is there anybody on Zoom that could share one sort of small problem in a sentence?
We had one, James, in the dialysis unit.
Yeah.
The problem was adjustable wheelie stools moved too fast when sitting on them when used on lino floors.
Oh, very good. That's an interesting problem. I'm interested to find out What's the consequence? Why is that a bad thing?
If you go to sit on it, the chair itself, the stool had 4 wheels which were unbraked. And if you were sitting at the bedside, you're about to sit on it to take somebody's needles out following dialysis, the chair itself could actually move out from under you, which meant that you potentially wound up on the floor.
Oh, right. That's quite bad though. That's a safety problem for both the patient and staff. So yeah, that's a small problem, but quite important.
Can I just say that's not limited to dialysis, it's also a problem for shorter staff in theatres who are too short to sit on the stools on main floor.
Yeah, we've got some nodding of heads at the back there as well.
In physio outpatients, we had the same problem too, Blair, and we solved it with the same solution, but we came across an unintended consequence, which was that patients sometimes sat on these stools, patients whānau did, and they thought that they were stationary because they didn't move immediately. And then they sat down and got a heck of a shock, and we had a couple patients fall off these newly altered caster wheels.
Yes. So same issue. When not in use, they're withdrawn from the public area and placed in the office for that reason. But the solution we found was to fit a wheel that was designed, again, unbraked, because having brakes on wheels can be really inconvenient, but has a greater resistance so that the chair itself, until there's weight applied to it and is intentionally moved, doesn't actually shoot out from under you. Works very well, and we've not had any more staff on the floor.
Great. Well, we're just going to work with this problem for the last 5 minutes. I'm sorry we can't get everybody's ideas, so it would be really lovely to do that. But so in terms of talking about your problem, the problem is these things, and what would you measure, and what would you hope to, what measure are you hoping to measure to improve if you were going to see this project through in a PDSA way?
I guess the outcome we were looking for was the elimination of staff falls from these stools where they were expecting it to be beneath them when they sat down, and it either tipped or moved, and that was the outcome. That was the goal.
That's the outcome measure. And can you think of a process measure? Or anybody else in the room?
Technically, if people are falling like that, that should be recorded as a health and safety incident. So you should be able to track that they're going down.
Yeah. But can you think of a process measure? So the outcome is people falling, but can you think of any processes that might measure not the actual outcome, but the process getting better?
Near misses.
Could you look to see how many people are using the seats?
Yeah, good one. So the number of people using the new seat. So you could maybe put one new seat and an old seat in the same area and see which one people gravitate to after a period of wash-in, for example. Yeah. And sorry, Emil, you said
near misses.
Near misses. So if you could try and maybe observe what people do and see if they almost fall, but not quite hit the ground because they can save themselves. That's good. So those are some process measures, and the balancing measure. Well, one was given was patients sitting on them and falling down. So that would be one. Is there any other balancing measures?
Inspection survey.
Okay, inspection survey. Good. So then we got our measures and the change. What would we do in our first PDSA cycle?
You just change one chair instead of more than one.
Yeah, one chair for maybe a week. I think if you did it for a day, people might kind of stare at it most of the time. But if you had it there for a bit longer, then people might get used to it and try it out. And then one chair, and if that works, then you might then buy a few more chairs. So
James, sorry, jump in there. I'm going back a step because I thought of something which has occurred for us, which is a balancing measure. The unintended consequence, because we've done this, is that the stools don't function so well in the carpeted office. So I'll come back to that. I'll come back to that point when you've carried on.
Yeah, that's right. And maybe you might also just basically want to survey people at the end and see overall what do they prefer as well, to see if yeah, you might have reduced the outcome measure, but actually people don't like them, for example. Yeah, so then you would then try it out and you buy it. So how many of those chairs have you bought now?
We've got 4.
Okay. And I presume there's a lot more normal chairs than there are these safer chairs.
Yep. So a standard wheelie chair is not used outside the office, but these stools were more intended as a clinical seat where you did need mobility.
Yeah. Good. So if you ever wanted to produce a business case to buy another 20 of these chairs, then some of this data from your PDSA would actually be very useful for such a business case. Great. Well, we've come to the end of our hour. Well, it's 5 minutes to go. I don't want to keep you late. So are there any questions about the model for improvement, about these things, or any comments you want to make? Yeah, it's hard. Change is hard. That's absolutely right.
I think it just reminds me that start small. That's a hard thing.
Yeah.
Because we all want to change the world.
Yeah.
But really, it's just start small for me.
Yeah.
It's stick to one problem.
Yeah. Good.
And knowing that 15 to 20 years it takes for guidance to go to practice, I set my goal maybe to change a couple of things in my life.
Yeah.
That's it.
Well, yeah. I mean, I think if you had just one thing that you actually made a significant impact on patient outcomes, safety, and stuff, I think that would be quite a big goal. Yeah. Okay. Thank you very much, everybody, and good luck. I'll see you next month, hopefully.
Thank you.
Bye bye. Thanks to everybody on Southland and Zoom as well. Bye.
Thank you, ladies.
Yeah.
What?